So my name is Joyce Wanyonyi and I'm presenting on behalf of Kenya Red Cross. You've been told earlier on Kenya Red Cross is the principal recipient 2 of the Global Fund grant. The principal recipient number 1 is the National Treasury. He's just left the stage. And principal number 2 for the HIV grant, that is Kenya Red Cross. AMREF is the principal recipient 2 for malaria and HIV. So in terms of the grant updates, I'd like to give you the figures in terms of where we are. So those are the figures. We got 77% of the disbursement from Global Fund and we spent 50%. Next. So that is the status in terms of what was disbursed to our partners. Currently, we are supporting 65 sub-recipients across the country. So we were able to disburse to them 98% of the grant that they had applied for. And the absorption, that is what they were able to spend against their signed budgets, was 63%. Next. So in terms of programmatic achievement, as Kenya Red Cross, there is what we've signed against the performance framework. So we have specific indicators that we do present to the donor, and that is the status in terms of the female sex workers who are able to be reached with comprehensive HIV prevention services, that is including the clinicals. We were at 96%. In terms of HIV testing, we were at 47%, and majorly because of lack of the test kits, that was shortage across the country. So in terms of those who are eligible for PrEP, because PrEP, we are also using it as a prevention measure, we were at 29%. And again, it's because of the erratic supply of the PrEP commodities and also the HIV testing kits, which goes hand in hand. For the MSM programming, we were able to reach 77% of the MSMs with defined package of care. That includes also the clinical services. 62% with HIV testing and 13% with PrEP. And in terms of the comment, it's because of, again, matters of initiation and also erratic supply of the PrEP and HTS commodities. Next. For the people who inject with drugs, again, we have a defined package of care. That is 90% of them were able to be reached with the services. For those who are on MAT, we were able to retain 58% of our clients. And those who are able to be reached with, now among the total population of the people who inject drugs, again, we have a special focus for the female injecting drug users. So 80% of them were also able to be reached with the defined package of care. Again, in terms of now looking at the young people aged between 10 to 24 years, that is our adolescents programming, we were able to reach 45% of the target that we signed against the PF. For the treatment care and support, that is defaulter tracing, we were able to reach 57% of the target. Next. So in general, some of the other programmatic updates that I would like to share with you is there was a revision in terms of what we define as the defined package of care between the NFM2 and NFM3. So for NFM3 is what are the updates that we are getting right now, and that is the period between July and December 2021. So currently we are looking at those who have been able to be screened for the STIs, and those who have been reached with health education and also change of sexual behavior and condoms, that is for the female sex workers program and MSM programming. Now, for the harm reduction program, we are looking at the needle and syringe program. We are also looking at STI screening, TB screening, Health education, condoms as a package. Health education and adolescent sexual and reproductive health risk assessment and counseling on safe behavior for the adolescents, girls, and young people. It's a new component that is being piloted across the 5 counties in the country. So again, PrEP has been of interest as a program, and we are looking at how do we then increase the sensitization on PrEP and also engagement of PrEP champions to be able to increase the uptake. Because even looking at the programmatic, the quantitative data that I've just shared, you realize that PrEP uptake has been a bit slow. In terms of shortages of HTS kits, again, it has greatly affected our targets in terms of the uptake, because unless we test, then we cannot be able to actually initiate treatment, and that definitely affects the whole HIV treatment cascade. Condom distribution, again, there were shortages, and still we do have, in terms of access to the condoms by the beneficiaries, an issue that is being discussed at the national program level, that is NASCOP, to see how then can we be able to resolve that. MAT retention, again, issues of transport challenges. Currently, with the incoming of COVID, we were able to actually start what we call mobile MAT dispensing, whereby we now move kind of to specific locations to be able to dispense MAT to our clients at the various hotspots, as opposed to having them walk to our 2 centers, for example, in Nairobi, that is Ngara and Mathare, for the uptake, and Mombasa, we also have a center whereby they dispense MAT. Again, lack of urine toxicology kits affecting the initiation to MAT program. Now, for our adolescents and young people programming, those are the key issues that we are looking at: accelerating of the EBIs and outreaches, that is evidence-based interventions, to reach the targets by at least April this year. Why we are doing this is because we want to maximize on the school holidays. Again, we are looking at the electioneering period, whereby now issues of outreaches is going to be affected, and we wouldn't want to mix the program and politics. So we are trying to work around that to see how best it will work for the betterment of the program. For that indicator that is in bold, is not yet due, that is NSP, the percentage of females aged 15 to 24 who dropped out of school in the last 1 year. And this is an indicator that we are looking at reporting on it come end of this year, because we are now tracking it based on this current grant. Next. So for treatment, care and support and human rights and gender indicators, we are looking at defaulters, and straight from our link facilities, which includes both private and public facilities. So of the people that were line listed at the health facilities and those who were traced back, those are the figures. And this is being done by the community volunteers, and these are mostly the peers. Going to the COVID-19 grant, we are at 20% absorption, and this is because of the delay in terms of receiving the funds from Global Fund. So we've been able to sensitize our various networks, that is for the people living with HIV, for the adolescents and young people, the KP networks, to be able to prepare them to respond to COVID-19, and also to be able to also disseminate the same information to their peers. Again, we were able to do social protection in terms of cash transfer to 2630 beneficiaries in those categories. We have ongoing PPE distribution. Now, currently in this grant, the grant is covering 46 counties, and we are implementing with our 65 contracted partners and other networks or groups within the counties to be able to increase coverage. Next. Yes, in terms of procurement, we've been able to have the WAMBO system in place, and I know in our last meeting we still had issues around the contracting and finalization about the WAMBO system. So items are actually awaiting delivery. I can report on this. And distribution has actually been planned so that once we get the commodities in, then we can simply be able to roll out in terms of distribution. So for the other PPEs, the sanitizers and reusable masks, for the previous grant, whatever you were awarded, you were able to receive and distributed. Next. Yes. The other important commodities that we procure at PR2 level is the NSP Kit 1 and Kit 2. So again, this is, I can say we have stock in-house that can last us up to end of March for Kit 2 and end of April for Kit 1. So for the Youth Wellness Center, we have one that is operational. The other 4 we've just finalized in terms of renovations and fabrication of the containers, apart from the one that the one in Kisii that we still having structural finishes to be done. So in terms of the prevention centers under NASCOP, the 4 container fabrications done as Mombasa one was non-responsive. Because remember, we were talking to NASCOP and also working closely with the counties to be able to identify which are the areas that they prefer or which are the prevention centers that they will want to be revamped. So for Mombasa one, we still haven't done anything because the county was non-responsive. So we are still vigilant in terms of monitoring COVID-19 in terms of the surges. Next. Yes, so those are the challenges and mitigation measures that we have put in place. So currently we've had a lot of whistleblowing from our partners, and these are the CBOs. For some, we've had to do our background check, and even those who are doing the whistleblowing, even recanting the information. But as a grant, we've had our audit team in place, and we are currently vigilant on such kind of issues. Then inadequate project management budget to support our partners in terms of implementation. So we are actually tracking our savings to be able to support this. Then low rate of target achievement. Again, we are having meetings with our partners and just looking at what are some of the best areas of improvement that we can perform. We can be able to tap on. Again, lack of VL testing. This one I can't overemphasize because it's something that cuts across. Sometimes we are lacking reagents, other times we are lacking so many other things in terms of the VL testing. So you find that up to now, it hasn't really picked. Some of the hotspots are actually closed and they're yet to open. So this affects especially our programs that rely on outreaches. That is the prevention mostly for the AYP programming and KP programming. So again, inadequate funds every first month of the quarter, because unless we have reported to the donor and the donor is satisfied with the reports, then we can't be able to receive funds from Global Fund to be able to disburse to our partners.
Thank you.